sir, Atanu sir.
Good evening, respected members. It is my proud privilege to welcome our President IAP Bangalore, Dr. Raghunath sir, first and foremost, Dr. Basavaraj GV sir, President 2024, National President, Dr. Vasant Kalatkar sir, National President 2025, Dr. Singarvelu sir, President-elect 2026, Dr. Ruchira Gupta madam, Secretary General IAP Bangalore, Dr. Alok Bandari sir, Dr. Yogesh Parikh sir, Dr. Atanu sir, Dr. Geeta Patil madam, the star of today's program, Dr. Sanjeev Joshi sir, and all the stalwarts, Dr. Sumita Nayak madam, past president of IAP Bangalore, and all the stalwarts to this wonderful scientific session. Without wasting much time, I hand over the podium to Dr. Nandi sir, our convener for today's scientific session. Over to you, sir. Nandi sir.
Thank you very much, Dr. Sunil. Very good evening to all the respected seniors. Again, I welcome our National Secretary General Ruchira Gupta Madam, National Treasurer Dr. Alok Bandari, past President Dr. Vasant Kalatkar sir, President-elect Dr. Singarvelu sir, National President 2024 Dr. Basura sir, and all the EB members, all the state office bearers, district office bearers, president, secretaries, and my dear friends. This is our greatest opportunity of IAP Bengaluru to invite you all to the first launch of our academic program, the Great Bangalore Connect. The aim is simple. We need to learn together with great people, you all, and it shows your commitment to learn together and teach ourselves about the topics. Monthly, we will have one program and with a meaningful academic discussions one-to-one, and the great speakers will be invited, and we are honored to listen to them and learn from them. I sincerely thank all of you for joining together. This shows that our academic venture will definitely be a successful event in this year. Now, I request our Honorable President IAP Bengaluru sir, Bangalore Dr. Raghunath sir, to give his presidential remarks. Over to you, Dr. Raghunath sir.
Thank you, Dr. Nandi sir. Good evening to all the dignitaries present, Dr. Basavarajji, Dr. Atanu Badra sir, Singaravelu sir. Singaravelu sir missed our inaugural function. I know he was very busy. Dr. Ruchira madam, Atanu Badra sir, and Dr. Sunil Joshi sir, and all the other dignitaries, Dr. Geeta Patil madam, and our Sumita Nayak. We welcome you all to this learning session. Of course, it may not be a learning session for all of you, but it will be a revision session for many of us. So we are grateful that all the bigwigs of IAP has joined here for this great Bangalore Connect. I am very thankful for your valuable time you have shared with us. Today, we are starting this first program, Great Bangalore Connect, which is going to help our postgraduates as well as our practicing pediatricians to manage the first unprovoked seizure, which is always a jittery thing. Somebody comes with a seizure in the middle of the night with a during his sleep, whether we have to take it as serious one or whether there is a seizure which is not associated with fever with a 9-month child. All these things are going to be elaborated by Dr. Sanjeev Joshi, who happens to be the director of Chigayu Critical Care and Joshi Children's Hospital from Maharashtra. His sir is also ex-national secretary. Yes. So we have almost reached the brim of our this thing capacity. We have about 92 people already logged in. Without
Sir,
much,
sir, madam join ಆಗಿದ್ದಾರೆ. Welcome.
Neelam madam.
Neelam
Neelam
madam
madam has joined.
welcome, Dr. Neelam Mohan, madam. Thank you for joining this session. And we
I
are
think you forgot that I have been given an honorary fellowship of Karnataka State.
yeah.
So now I am a Karnataka, so I have to join when you have started your opening batsman with another Dr. Joshi, head of Maharashtra. So yours truly joined.
Thank you, madam. Thank you for being around. And with these few words, I would like to thank all the dignitaries who have come and joined this session today, and hope this session will be more successful in future. And we are starting with Sanjeev Joshi sir, who is a reputed neurologist. So we have with this starting is going to be a stepping stone, which will be a milestone in the IAP Bangalore. With these few words, I would like to end my speech, and thank you very much for giving me opportunity. Over to Nandish.
Thank you, President Raghunath sir. We are very glad to have our Central IAP President, Dr. Neelam Mohan Madam. We welcome you, Madam, on behalf of IAP Karnataka, IAP Bangalore, and all the dignitaries here. I request you to give your blessings to us with your remarks, Madam, to the program.
Thank you so much, Nandish. It's indeed a delight and privilege that we are able to do the teaching through digital media, and every time we improve our knowledge, every time we save more children, and ultimately this is the way we can contribute to the improvement of health infrastructure and care in not only Andhra, in not only Karnataka, but nationally. It is so important to see that when leaders join together, I'm sure everyone will emulate, because we want them to emulate us. Let us set an example that people like Dr. Basavaraja is sharing the message, which means so much. He is sharing the message, not youngsters. So I hope the youngsters learn from this, that they need to also share, and they need to also learn, because always learning and relearning is the art towards improvement. That's all I have to say. Thank you so much, and wish you all the best for a brilliant learning. And so am I, all ears to see what more I can learn.
Thank you very much, Madam. With your blessings, definitely we are going to have wonderful academics and learn together. I now request our Honorable President-elect, Sir, Dr. Singaravelu, Central IAP, to give his best wishes to us for the academics.
Thank you, Nandi sir. Respected President Neelam Mohan and past President Vasant, chief guest today, none other than my President Basavaraj sir, and today's speaker Sanjeev Joshi. And Bangalore is not new to me, because Raghunath sir and Sunil sir, Nandish, Geeta Madam, Sunita, all it is second home for me always, because I have been connected previously. Everybody is here, and it is a great opportunity. And see, now the Zoom is full. People will be waiting. Unless we people should leave, others should, because already 100 is reached. It is the interesting thing, the amount of knowledge with Bangalore, always known for academic. Surely this Bangalore Connect will be very useful to all the practicing pediatrician. I'm very happy to be part of it. Over to you, sir. Thank you for giving me this opportunity. Best wishes to all of you.
Thank you, Singaravelu, sir, for all your blessings. Now I request our immediate past President, Dr. Vasant Kalatkar, sir. We are very glad to have you here. Please give your best wishes to us, sir.
Yeah, all dignitaries from IAP, respected my Bangalore friends, and Nandish, Dr. Sanjeev, and President Bangalore. Thank you for calling me and inviting me for my 2 words of blessing. It's Bangalore is always in front for academics, always. Nobody can beat Bangalore. That's why I think there are so many brains, all type of brains are there always. And really, as the convener, Dr. Nandish is doing the great job that is utilizing the brain. And sharing knowledge is always best of the best. And really, I'm proud that you are going to start with the Maharashtra. That is our president, who is the Sarva Sarva of our. That's a who is the key person. Dr. Sanjeev Joshi is our key person. मेरे को भी उसका ही सुनना पड़ता है as a Maharashtra member. So really, thank you once again for that your speaker, you are choosing for speaker is Dr. Sanjeev Joshi for today. His depth of knowledge in neurology, you all know, he is working since last 15 years in the field of neurology. Really, they doing a great job, and it's like in spite of his living in Yavatmal, that Yavatmal is a small place, but his thirst for academic is too great. Nobody can beat that thirst. So this is a best choice. Thank you, Nandish, and thanks all for every support last year. And I hope if I will be useful this year also for you people. I'm always ready. Thank you, Dr. Singaravalu, Dr. Neelam, Dr. Ikira, and all Dr. Alok for joining. Thank you. Dr.
Thank
Basavaraja,
you.
actually, this is the key person for Bangalore. Dr. Basavaraja, thank you. Yeah. And I wish
Thank
all
you,
the best.
Vasanji. Thank you. Thank you.
Thank you, sir. Your wishes will always guide us to give our academics to all our members. Now I request our honorable guest, Dr. Ruchira Gupta, Madam, Honorary Secretary General 2627, to give her remarks and wishes for the academics.
Thank you, Dr. Nandish, sir. Respected President, Dr. Neela Mohan, Madam, President-elect, Dr. Singaravelu, sir, the past presidents, Dr. Vasant, sir, and Dr. Basav Raja, sir. The speaker for today, Dr. Sanjeev Joshi ji, and the executive board member of 2026, Dr. Priya Shivali, Dr. Ajay Arora, and Dr. G.S. Chaudhary, and the president of IAP Bengaluru, Dr. Raghunath CN. He was my co-EB in, I think, in 2019, if I'm not wrong, and Dr. Sunil sir and Dr. Godbole, and all my very dear friends and colleagues and seniors, as well as all the colleagues, IAPians. A very good evening to one and all. And I wish to say that this launch of Bangalore Connect series, a very innovative one, especially for postgraduates. This initiative IAP Bangalore has taken. It is a commendable initiative to strengthen PG learning as well as clinicians learning, as well as academic engagement. So I'm sure, and especially the topic which you have chosen today, that is approach to unprovoked seizure. It is a topic of practical evaluation as well as evidence-based management is required for this. And I will like to wish you all the best for success of this program, many more to come. And thank you for having me over here. Thank you very much.
Thank you very much, Madam, for your wonderful words, blessings. This will take us ahead, definitely. Now I request our National Treasurer, Dr. Alok Bandari, sir. We welcome you, sir. I request you to please give your comments and wishes, sir.
Well, good evening, friends. It's been a great evening today. And I always consider B for Bangalore and B for Basav Raja. So whenever we think of Bangalore, we always think of Dr. Basav Raja. And also, he is a very cricket enthusiast, and whole city of Bangalore is cricket enthusiastics. And I compliment Dr. Nandish for hitting century on the first innings only. More than 100 participants have joined this uh, today's webinar. Opening shot he has done with 100 more than 100 participants, which is a rare thing these days on webinars. So that speaks volumes of the credibility of the organizing team and the entire people who are behind all this, and obviously popularity of Dr. Sanjeev Joshi and the topic also given to him. And I think I should not be taking much time and hand over the mic back to organizers with the best wishes for an excellent program that has been carved. And Bangalore is definitely connected very well to the whole of the country. Thank you,
Thank
please. Thank you.
Thank you, Alok Bandari sir, for your wonderful wishes. I think limit is the 100. I think many friends are messaging me, not able to join, not able to join. If possible, kindly take care, Sunil Kumar, to increase the membership strength to join. Friends are waiting to join.
Thank
Thank you
you.
very much, sir.
YouTube link can be shared. Yeah.
Yes, sir. Yes, sir. We are recording, sir. We'll share it, sir.
Okay.
Thanks.
Thank you very much, sir. All our state IAP Karnataka President Dr. Ravi Shankar, sir. I request you to give your opening remarks, sir. Ravi Shankar, sir. It's not there. Okay. Okay. Yeah. Now I request our chief guest of the program, Dr. G.V. Basuraja, sir, known for his academics, leadership, inclusiveness, and whatnot all. For everything, we can tell Dr. G.V. Basuraja as an example. We are very honored to have him as chief guest here and launch our Great Bangalore Connect program and spread the academics across Karnataka, Bangalore, across the borders and in India, throughout India. I request you, sir, to kindly give your chief guest address and introduce the speaker, Dr. Sanjeev Joshi, also, sir. Please.
Thank you very much, Dr. Nandish, for starting with an excellent initiative under the leadership of Dr. Raghunath, who was the Honorable President of IAP Bengaluru and very well known across the India, who has made a big name. Of course, with the Dr. Sunil Kumar, who has been shouldering the responsibility to shoulder. And with the galaxy of a presence of our national president, Dr. Neelam Mohanji, Honorary Secretary General, Dr. Uchira Gupta ji, and of course, our president-elect, who has been also in a very close to all the Karnataka and Bengaluru, our president-elect, Dr. Professor Singaravelu sir. He is a part of our Bengaluru only. And our immediate past president, and also in a past neurology chapter chairperson. Neurology is close to his heart, Dr. Vasant Kalatkarji, and Alok Bandari ji, who has been very instrumental in taking all the academic activities and neonatal things. Now, as being a treasurer, I am sure that things at the Central AP will reach a greater heights, and all the past national EB members and present EB member like senior members like Ajay Arora ji, Lakshman Kumar, Renu Boralkar, our Maharashtra IAP secretary, Dr. Priya Shivalli, and all the other members. See, the Great Bengaluru Connect, it is one of the great initiative of a team 2026 with the anchoring role by none other than Dr. Nandish, who has been very much connected with all the faculties and all, along with Dr. Kushal Kumar and of course Sumita Naik. This is an initiative which definitely it is going to make a big things. When the year 2020, when we started a digital thing, everybody was excited. I was the first one to give a talk, that is in March 2020. That was on a coma, approach to a coma or unconscious state. Where I remember around 3,600, something like that. 3,600 at that time, it is a huge number. Then digital things which continued. One of the webinar which was 10,000, because during the COVID time, that was the reach, how we could be able to connect it. We thought after the COVID disappeared, this digital thing also will disappear. But it is not so. Things, it is going to stay. Only thing we need to look at the innovative things with the innovative way of choosing the topics, innovative way of how do we connect with the people. That's what Bangalore Connect, which has been done. Choosing a topic which has been a very close to the pediatrician, not only pediatric neurologist, it is very important for a pediatrician's perspective. We are in a crossroad at this stage where the pediatrics and pediatric subspecialties are emerging. As a pediatrician, where do we stop? When do we refer to the pediatric neurologist? It is not only the unprovoked seizure, there are many things which has been topic like this, which belongs to the domain of a general pediatrician and also to the specialist. Because specialties is yet to mature, where pediatrician as well as specialist together has to be connected to the give a quality of care to the pediatric patient. That's where we are all working for that. You are not only has to work like a general pediatrician, you also need to work with a specialist knowledge too. That is where we are in a transition stage of pediatrics. That's the reason why pediatric subspecialty is yet to be mature. The pediatric rating which has been gone down. But as a pediatrician, we need to connect it back so that our glory of pediatrics and pediatric subspecialty is going to be there in the next decade. So Sanjeev Joshi is the best example, the great speaker who has been chosen for the first topic, that's for unprovoked seizure. Why I said he is very, very apt for this topic. Reason being is, he will bring what is as a pediatrician can bring it, and also what as a specialist needs to be looked in. So he is a blend of both pediatrics, as a how good pediatrician and also the pediatric specialist. So Dr. Nandish has chosen, and the IAP Bengaluru team Raghunath has chosen a right person for the topic, that is Dr. Sanjeev Joshi. I remember when I attended a few conferences on neurology, Sanjeev was a secretary. It is a mixed crowd. It is a both pediatrician and neurologist too. So they are very, very eagerly, enthusiastically conducted in many of the academic activities with the Dr. Vasant Kalatkar's guidance. So this is the what Dr. Sanjeev Joshi is going to elaborate today, with a rich experience of last more than 2 decades as a neurology, and of course more than 3 decades as a pediatrician, and working in a resource limited setting. Is going to bring in all those things into it, how we need to practice the present day of a neurology as a pediatrician. And I know Dr. Sanjeev Joshi, who is a neurology chairperson, neurology secretary, executive board member, now as a Maha IAP president, who has been leading in a more than 7,000 member pediatrician, one of the biggest branch of India, who is spreading the knowledge, is an apt person for this. The best wishes for the today's scientific session. So I'm sure the things which is going to come in the future will also be much more informative, and people is going to be benefited out of that, both pediatrician, pediatric specialist, and also the postgraduate and fellows too. The best wishes for the today's program, Dr. Raghunath and team, for doing a wonderful academic work with the guidance of Nandish, Kushal and Sumita. Thank you very much.
Thank you, Basuraja sir, for wonderful remarks. Your blessings will definitely take us ahead. Sir, I request you to launch the program by pressing the enter button, sir. Basuraja sir.
Yeah.
Volume, Mr. Thank you, sir. Thank you for inaugurating the program. I do now request the great academician, IAP Maharashtra State President, Dr. Sanjeev Joshi, sir, known for his academics and his expertise. I request you, sir, kindly start the program and let us learn. Before sir starts, I request all the esteemed members to mute, and any questions, please put the questions in the chat box. We will note the questions and sir will take up the questions at the end of the program. Our sincere apologies to those who cannot attend the programs today. Definitely link will be shared to all and learning will continue with all. Sir, Sanjeev Joshi sir, please start the program, sir.
So, very good evening to all from the state of Maharashtra, from the Academy of Pediatric Neurology. I think we call in Kannada, good evening, Shubha Sanjay to all. Okay. So, Honorable President Dr. Neelam, President-elect Sir Singaravelu Sir, Secretary Ruchira, IPP Dr. Vasant, and my beloved leader, the Dawn of Bengaluru, my President of 24, none other than Dr. Basavaraj Sir, Team Bengaluru, Raghu Sir, Sunil Sir, Godbole Sir, Geeta Ma'am, of course Dr. Sumita, Dr. Ruchira Gupta, Dr. Alok Bhandari Sir, and all the luminaries and the dignitaries of the Central IAP, the state, Karnataka State IAP, and Bangalore IAP, and above all, the person who is instrumental for bringing this academic activity, launching this activity, is none other than my very good friend Dr. Nandish. If at all, I will definitely recommend, if not to the union government, but to the Karnataka government, if at all they want to rewrite their constitution or amend their constitution, you have a best resourceful person. Friends, I was just going through this list of dignitaries and luminaries, and it is not just a great Bengaluru connect, but I was feeling that I am just standing in front of a Burj Khalifa of IAP. So such a towering personalities are there. So my extremely humble salutation to all. I'll start I will start sharing my screen to the subject. My target audience will be practicing pediatrician and postgraduates. So I welcome all the attendees on this virtual platform for sparing their valuable time and gathered here to share this wonderful academic activity. And Nandi sir, it is not just a academic connect, but it is a activity of strengthening the bonds. It is activity of emotional connect also. And
thank you, sir.
Really obligated for this wonderful opportunity. So let us come to the subject proper. So my objectives will be define and diagnose seizure and rule out the mimics, because for every seizure activity you have a mimic in pediatrics. Understand the rationale for obtaining test or not after a first unprovoked seizure. Be able to provide advice and reassurance to the parents of a child who just had a first seizure. That is very important. Recognizing the basics of starting some of the more commonly used anti-seizure medication, if at all the child fits into it. Now let us define what is a provoked and unprovoked seizure. Since we are defining here the approach to the unprovoked seizure, we must know what are the provoked seizure. Provoked seizure, there is always a trigger which is provoking it. It could be some infection, trauma, inflammation, fever, intoxication, hypoxia, and metabolic. You know, most of the medical diseases have these etiologies only. And what is an unprovoked seizure? It is not associated with an obvious trigger, and it is beyond the age of 1 month. Because below the age of 1 month, any seizure, it is a different set of game. And sometimes this first unprovoked seizure could be related to epilepsy. Now let us first define what is epilepsy. It was defined in the year 2014 by ILAE that more than 2 unprovoked seizures 24 hours apart, then 1 unprovoked seizure with a 60% or higher probability of more seizure over the next 10 years. So it was a risk stratification of recurrence of the seizure. How we can do it, we will see in the subsequent slides. And a single unprovoked seizure with an EEG diagnostic of a specific epilepsy syndrome. Because we know in the current era, epilepsy syndrome is one of the best things which has been there in the pediatric epileptology, and it is a constellation of the sign and symptom with an age-specific onset of seizure and also a electroclinical correlation. So if that first unprovoked seizure is having a EEG correlate, we can still label it as a epilepsy syndrome, and we can start the treatment. And now this is the latest classification of the seizure by ILAE. We must be wondering that why this bloody ILAE go on changing the nomenclature and putting on new and new classifications every 2 years or 3 years. But friends, ILAE wants to simplify the things. So there are now 4 main categories of the seizure. I am just touching this slide, because if at all I go on explaining this slide, it is itself is a 20-minute talk, 20-25 minutes. So I will just touch upon the basic version of the October 2025 classification of the seizure. And the seizures are classified into main 4 groups: the focal, the unknown, when we don't know what how the seizure has started and what we have experiencing, the observing person has experienced; generalized, of course, right from the beginning the seizures were generalized, and some things still could not be classified, they are unclassified. So these main 4 categories are further, focal are further divided into 2, with the preserved consciousness and with the impaired consciousness. Friends, you must be listening to the term of awareness in the past, but not that awareness is gone. Now we have come with the consciousness, whether the child was having preserved consciousness or an impaired consciousness with the focal seizure. And even in an unknown onset seizure, whether focal or generalized, still we have to do a dichotomy of a preserved consciousness or an impaired consciousness. And of course, generalized, we have specific semiologies like absence, some other generalized seizure like JME and generalized tonic-clonic and all. Okay, now the morbidity with the seizure is in this yellow zone. When the focal seizures become bilateral tonic to clonic, and if they are not aborted, then there is a high incidence of morbidity. Of course, when we have an unknown onset, but we are viewing it as a bilateral tonic-clonic again, and when a generalized tonic-clonic seizure. So this yellow zone is related with the morbidity. And what are the changes? Well, there are 4 key changes were made by the ILE. Onset is removed from the name of the 4 main seizure classes. Previously, we used to classify focal onset, generalized onset, and unknown onset. Okay, now the onset word is gone. The ILE doesn't have to deal. We don't have to deal with what was the onset. What actual you are seeing, or what actual the parents has narrated to you, or what actual the parents has captured in the video. Consciousness is replaced by awareness as a classifier, because consciousness also includes responsiveness. Consciousness also not only include awareness but also responsiveness. The motor and non-motor dichotomy is replaced by observable manifestation and non-observable manifestation. Seizures are described by the chronological sequence of sign and symptoms rather than by relying solely on the first sign. This is a very important 4 changes which has been made. Now if to understand the concept of epilepsy, you must understand this table. And these are the 5 level classification of the epilepsy, 5 level. The first level is seizure identification. When the seizure classify as per the ILE class criteria to be labeled as epilepsy, then you have an epilepsy type: focal, generalized, combined generalized, and focal and unknown. And if at all there is, ILA always puts a thrust on recognizing the epilepsy syndrome. So try to recognize some epilepsy syndrome when you have a specific constellation of semiology of the seizure. Then you have a specific EEG correlate, and you have a specific age of onset, and you have a specific age of remission of the seizure. Of course, you have to address the comorbidities also. And now none of the epilepsy is unknown etiology. Now most of them always try to find some etiology to the epilepsy. It could be a structural, genetic, infectious, metabolic, immune, and few epilepsies are now unknown. Now all patients with epilepsy, I don't know why this is going on. Why these lines are there? I really don't know. Who is doing something? Anybody playing with this? Dr. Nandish?
No,
Why?
sir. Continue,
Why
sir.
this?
Let us see. Continue, sir.
Why these
No.
lines are
That
there?
sorry, you that is annotations. So you just you have to reset it right at the top. No, you'll have annotation tools. You have to reset it. Somebody is
Okay.
obviously having access to it.
Oh. This one.
Dr. Sunil Wost, can you please attend to that?
Okay.
What to do, sir? How to clear it, sir?
Yeah, you just come out, you just stop it and then go back again. It's a restart. Share again. It will be fine.
Stop sharing and reshare.
Yeah. I'll do that. Sometimes technology plays its game. Some unseen hands are there. Okay, so we got it. So all patients are epilepsy experiences seizure, but not all individuals with seizure have epilepsy. And the first seizure may not be the first. Now, the question we must ask, was the episode was that paroxysmal event was an epileptic seizure or it was a non-epileptic event? So making a correct diagnosis in the first transient neurological event is very, very important, because the literature says that almost 30% of the cases referred are misdiagnosed as epilepsy. Because I have already told you in the beginning, for one seizure semiology there is always a seizure mimic. So there is very important need to identify more common non-epileptic paroxysmal episode, which are more commoner than the seizure by the practicing pediatrician. Now history. Friends, neurology is all about history. So what was the age of the onset? At which particular age the seizure was there? Because I have already told you, some specific some epilepsy syndrome they will start at a specific age. If the seizures are below 6 months, 3 months, then of course you may be thinking about structural, metabolic, neurometabolic, or some genetic issues like. So what was a provoking factor? So we have already discussed with the provoking factor. What was the preceding events? Whether there was some aura, whether there was some kind of stressful situation, and what was the timing of the event? A nocturnal event is always seizure, unless proved otherwise. If the child is in the verbal age group, aura he can describe. And what was the actual seizure semiology, which we called is an ictal event. So what was the ictal event? Like it was it started from one side and progressed to another side. It was myoclonus, it was tonic or clonic or like that. And most important is a post-ictal. How the child was behaving post-ictally. How long was the drowsiness? Was there is any neurological deficit? These things should be taken out from that particular event. But at the same time, you must probe the birth history. It could be one of the effect of the perinatal insult. The family may have a predisposition for the epilepsy. So family history, consanguinity, how the developmental history of the child is very important in neurology. If at all a developmentally delayed child or a developmentally normal child getting a seizure, the approaches will be definitely different. And what are the comorbidities? We are in the now ocean of autism, the sleep disorders and all. So identify comorbidities also. Diagnosis of seizure reliably depends on a good history, taking and review of a video and recording of the video. You know, friends, one video worth thousands of the pictures. So if at all in the era of the smartphone, if the parents can capture the event, it is nothing like that. Now, what are the common seizure mimics? I have classified them according to the age of onset. In the newborn, we see jitteriness, benign sleep myoclonus, sometimes reflux, then the gratification disorder. Among the toddlers, you have breath holding spell, inattention behavior, daydreaming, older children's, tics, stereotypies, syncope, lethargy, rigors, sleep disorder. I'll just touch upon these things. I will not go into the detail because our discussion will be focusing on the seizure only. Just anybody from the postgraduate can recognize this paroxysmal event. Child was crying, holding the breath, and now this, yes, a classical breath holding spell. This is just 2 months old. The parents were, mother was complaining that he is having these movements in the sleeping time only. When he was awake, there were no movements. And the child was already had been put on to anticonvulsant without any effect. So what is this? These are few benign normal situation called as benign sleep myoclonus. This is a picture from NICU. You can see the lower limbs, jitteriness. Of course, can be confused with the seizure. And this is another very, very curious boy. What is this? This is a shudder. Sometimes can be mistaken for a epileptic spasm. Okay. And this is a very common situation. Patient comes to me with 2-3 USG ultrasound and other investigations also. This is very classical self-gratification disorder. So these are the few commoner seizure mimics. And one of the most tricky situation in neurology. So what is this? These are nothing but paroxysmal. These are psychogenic, non-epileptic seizure disorders. So the difference, the most important thing is you can very well appreciate that he is trying to close his eyes. Closing of the eyes is very important during a PNES episode. Then the semiological features are like pelvic thrusting, swaying and all. And he can obey the command also. If you just ask him to stop, he will stop. And if you again request him to restart, he will restart. So these should not be mistaken with the seizure. And this is a girl, C. So this could be again confused with syncope also, with tonic seizures also. See, if it would have been a syncope or some atonic seizure, the girl would have fallen, but she had not fallen. I have purposefully, I'm not showing the face of that girl. So these are the PNES, very common. Now, from the clue, in the story of that particular event, what are the clues which will favor that this was a seizure more likely and not a seizure mimic? So if the onset is during day, night, awake, sleep, without any trigger, more likely to be a seizure. If there are signs like behavioral arrest, eye abnormality, focal motor signs, tonic stiffening, stereotypy, more likely to be a seizure than a non-seizure. How the event evolved? The child was unresponsive. There was a generalization, what we used to call Jacksonian march in the past. Typical evaluation. There are certain events like incontinence, tongue bite, injury. So these are the things which will favor that episode was a seizure one. Duration, it lasts very few minutes. And after event, slowly return to normal. All these things in the story of the child will favor the diagnosis of seizure rather than less likely to be a seizure mimic. Now look at this child. How you classify this child on the latest ILE. This is a 4-year-old male child. Everything was normal. Started these movements just from last half an hour 2 to 3 times. So there are clonic twitching movements right side of the face, lips are involved, eyes are also involved, and you can very well appreciate that the right upper extremity is also involved. The child is conscious, he is responding to stimuli, aware, he is aware and responsiveness. So 4-year male, right focal with preserved consciousness. So how you will classify this seizure activity like this? And this was a known case of epilepsy. Missed the valproate and landed with a generalized tonic-clonic seizure. Okay, this is another semiology. Now, this is a very peculiar case occurring in the night time only. The 5-year-old male, he has just looked at the right side of the face of the child and lips. You can very well appreciate the twitching movement on the right side of the lip, also blinking of the eyes with the behavioral arrest. He is not conscious. So, nocturnal event, right focal motor with impaired consciousness. During night time, there is some drooling of the saliva. This is another semiology. Okay. This was a 7-year-old child, had some altered sensorium and showing this typical semiology. Look at this. This has got a specific nomenclature of this semiology, which we call it as an automatism. He is having behavioral arrest, repetitive upper limb movement preceded by headache and aura visuals, and 2 to 3 episodes developmentally normal. So these are called as automatism. So friends, these are the few common semiologies which I have shown you. Now coming to the first seizure. Now there are 3 steps which are very important when you are addressing a parents of the child to be the first seizure. The psychosocial fear to address immediately. Always give more time than prescription when you are counseling the parents of the child who just had a first seizure. Then evaluation and whether do I need to start any anti-seizure medication. So reassurance is very paramount. So reassure them that a first seizure is not equivalent to epilepsy. All children look terrible during seizures, but children are breathing. Seizures are common. Children with epilepsy are normal kids. They should sleep in their own bed, should be in the school, sometimes can play video games. Most of the sports are acceptable, but except few like skydiving, hunting with guns and arrow, and scuba diving. Now, how do you start your evaluation of the first seizure? Of course, the diagnostic approach starts with the history and physical examination. Blood work not often needed, but as per the situation. Toxic screen, if at all there is a situation of exposure to toxin, then only. LP only if there is an evidence of CNS infection. EEG as early as possible or within 24 hours. Now, general examination. When my child who has just had a first seizure and having a company of this neurocutaneous stigmata, I must be very much careful. I must be very methodical in my evaluation. So, Ashley macule, chagrin patches, port wine stain on the face, cafe spot, and of course, there are any abnormalities in the anthropometry, the microcephaly, some hair abnormality, dysmorphism. My workup for the case for that particular case will have its own distinct pathway. A complete thorough neurological examination, friends, right from the level of alertness, focal neurological deficits, papilledema, raised ICT signs, and higher motor function, sensory, cerebral signs. So, when I talk about the neurocutaneous stigmata, I remember one important statement. Whatever brain try to hide, your skin try to reveal it. So, what are the जो भी brain के जो भी ये होंगे मतलब छुपे हुए कुछ दास्तानें होंगी द स्किन में ट्राई. So laboratory investigation, do I need all this investigation in the first unprovoked seizure? Not at all as per the clinical situation. But if I am dealing with an infant less than 6 months, serum electrolyte must be tested even if no clinical finding. Toxicology as per the situation. No role of lumbar puncture in children with first episode of unprovoked seizure. This is a very important bottom line. Now, EEG is very essential part of evaluation. Should be advised, but with the clinical background is very crucial. When you are referring the child for every pediatrician and a postgraduate, when you are referring the child to the EEG after the first unprovoked seizure, grab the first opportunity of doing that EEG as early as possible. Number 1 rule. Number 2 rule, provide all the clinical backgrounds to the person who is doing the EEG. He may be pediatric neurologist, adult neurologist, or maybe pediatrician well versed in the field of neurology. Mind well. First, when you are doing an EEG, even 50% of the first EEG could be normal. So a sequential EEG will improve the yield. And very, very important, up to 15% of the healthy children have abnormal discharges on the EEG. Why I am making such bold statement, friends? Because I have taken through the history in a pretty detailed way, because I don't want you to order EEG when you are sure clinically that this was a syncope, this was a slip myoclonus. So I'm really pretty sure that this is not a seizure at all. So please don't go ahead with the EEG if syncope is higher, stereotypy is higher, tics are higher on your priority. Now, role of EEG, it is the first very important. Within first 24 hours, ideal recording 30 to 60 minutes sleep and awake state with activation method. So you are remembering that child with a nocturnal seizure. If you don't provide that person who is doing EEG that the seizure has occurred during sleep time, so you will not get the finding. So provide all the details. So these are the activation methods like hyperventilation, then photic stimulation and sleep deprivation. Serial EEG will improve the yield. When to use EEG? Diagnosis of epilepsy syndrome, localization of epileptogenic focus, unexplained cognitive decline, behavioral changes, or language regression. Sometimes a diagnosis of non-convulsive status epilepticus. When not to use the EEG? To exclude the diagnosis of epilepsy. Friends, why this is in the red? Epilepsy, EEG is not diagnostic of epilepsy. Epilepsy remains always a clinical diagnosis. Of course, EEG is a diagnostic for the epilepsy syndrome, but not epilepsy per se. So never use EEG to exclude the diagnosis of epilepsy. So if at all you have identified a non-epileptic form disorder, never go to do an EEG. Neuroimaging, what are the indications? MRI is the preferred modality, and there is no need of doing an emergency MRI. It can be done in a planned way, and MRI should be seriously considered if you have an abnormal neurological examination, you have a neurocutaneous stigmata, the seizures were focal, and there are some focality on the EEG, and if the child is less than 1 year. This is the absolute indication of doing MRI. CT has got a very limited utility. I will skip this unless in the emergency department, trauma or hydrocephalus like thing. So how to summarize the evaluation? Basic life studies in the emergency are appropriate and reassuring to the parent, and if at all we are starting some anti-seizure medication, you must have some baseline laboratory. Do not get a head CT, but can get an MRI later. EEG in nearly all patients, sleep preferable, help to clinch the diagnosis of an epilepsy syndrome, suggest if MRI is needed. Now, situation where rules does not apply. If you have a classical epilepsy syndrome, you can skip MRI. That nocturnal seizure, which is classical semiology for the latest nomenclature of the Rolandic feature epilepsy, which we used to call, now we call it a select syndrome. Select. Okay. Seizure mimics. If you are very sure with the diagnosis of stereotypy, syncope, migraine, tics, skip EEG, skip MRI. Febrile seizure can skip both MRI and EEG. Now, the last thing, the $1 million question. Do I need to start anticonvulsant? No. We must recognize what is the risk of recurrence of that first unprovoked seizure. So overall 2 years risk is 40%. 20% risk with a normal EEG. But if you have an epileptogenic EEG, if any abnormality in the EEG, 65% chances of recurrence. Okay, this is very important. One of the risk factors. So what are the other risk factors? Abnormal EEG, MRI, seizure during sleep, symptomatic. There was a remote symptomatic. Sometimes the remote symptomatic epilepsy can play first unprovoked seizure, that some perinatal insult has occurred. Family history in the first degree relative. 70 to 80% recurrence if the second seizure has already occurred, and a neurodevelopmental delay. These are all the important risk factors where you must consider starting a long-term anti-seizure medication. So EEG wise, risk of recurrence after the first unprovoked seizure, normal EEG is 40%, but with an abnormal EEG is 71%. This thing I have already elaborated to you. No risk factor, would you start anti-seizure medication? There seems to be a worldwide consensus that it is not necessary to prescribe everyday anti-seizure medication treatment to children with a first unprovoked seizure. Decision to treat depends on individual risk-benefit ratio. Treatment not indicated to prevent ultimate epilepsy. Even if you are starting for some anti-seizure medication without proving a diagnosis of epilepsy, there is not going to prevent epilepsy in the future. And the risk of medication side effect. So the basic rule is do less harm. So always balance the risk with the seizure versus the morbidity and which the child will be having with the anti-seizure medication. This is a very fine balancing has to be done, and the treatment has to be the decision has to be individualized. Now, this was a wonderful paper, very old one, the AN paper, which state that treatment with anti-seizure medication is not indicated for the prevention of the development of epilepsy. Treatment with anti-seizure medication may be considered in circumstances where the benefits of reducing the risk of a second seizure outweigh the risk of a pharmacological or psychological side effect. And why I am quoting the word ASM, anti-seizure medication? Now we don't call this medicine as anti-epileptic drug. We call them as an anti-seizure medication. Okay, so but this was a very old paper. So then why to treat the first seizure? If of course the child is driving every day two-wheeler, going for coaching classes, NEET ko jara, JEE ko jara, the first presentation was status epilepticus. Very severe seizure, prolonged seizure. I had to start. A swimmer, I had to start. Child is terrified and the parent wants it. So, the most thing while you are counseling a parents with the first unprovoked seizure, you must empower them with the art of giving an abortive treatment at the home. So, what is the rescue therapy? Benzodiazepine. When to give? More than 5 minutes. If in a hospital setting, if you are struggling with the IV intramuscular midazolam has got level A evidence. Or if you have a good access to IV, you can choose anything which are available with you. Home, a non-IV midazolam like nasal, buccal or rectal. The most popular thing is a midazolam nasal spray, and this is a position where the child should be kept. Now, just I will go through the 3 cases and I will sum up very fast. Nandi sir, I have 5 minutes more. Hello?
Complete, sir. No problem. Complete.
Yeah. 4-year-old female child born of a non-consanguineous marriage, developmentally normal, while playing in garden became unconscious, and it was a classical generalized tonic-clonic seizure. There were some observation was there. One of the parents was there. There was no any past history of seizure in the family, no family history, no past history of seizure, developmental history normal, birth event was normal. Now, how you proceed with this? Now, we have already gone through the evaluation. Of course, would you do EEG? Would you do MRI? Of course, we'll do EEG. EEG done, which was normal. What next? Would you start anti-seizure medication? The important message in this case was there was no risk factor. EEG is normal. So, hardly the recurrence rate is not more than 20-24%. So, the treatment is reassurance, and wait for recurrence. No ASM as of now for this case. Second case, 15-year-old boy with first unprovoked seizure at 6 a.m. being late he was playing some video game and he was brought to the ER in the early morning, seen by some adult physician, was immediately subjected to CT. Urine toxic screen was done, it was negative, and he was empirically started on carbamazepine and told to see a neurologist. There are so many mistakes with this case. Parents wants to know whether they should continue this medication when they are seeing the neurologist. Unfortunately, what has happened? The seizures worsen on asking for further. That was not a first event. See, the history has to be very, very comprehensive in neurology. There are no shortcuts to history in neurology. On asking in a detailed history, the boy had a habit of dropping toothbrush in the early hours of the morning while brushing. Sometimes he has broken some glasses also in the family. Okay, so what was this story was pointing out? This child, in addition to generalized tonic-clonic seizure, with which he has presented to ER on that particular day, was not the first seizure. He was getting some myoclonic jerks in the morning. And being a 15-year-old, this was a classical situation of a juvenile myoclonic epilepsy, which was proved by doing this EEG, which is a very classical for electrical correlate for this particular semiology, which is, and the syndromic diagnosis is juvenile myoclonic epilepsy. And friends, when you have a myoclonic epilepsy, when you have a generalized epilepsy, carbamazepine will make that seizure worse. So all the sodium channel acting drugs like carbamazepine, phenytoin, phenobarbital, please refrain from using these drugs when you are starting any treatment with with epilepsy with myoclonic semiology, or even generalized epilepsy. Okay, so the ASM was changed to valproate. So, and the child has got a good control. So, the lesson learned are no empirical treatment, long-term treatment should be given without a proper evaluation. Okay. Never start anti-empirical ASM. Some ASM like carbamazepine can worsen few seizure type like myoclonus. Basic evaluation with EEG, and if required, a neuroimaging, preferably MRI, should be done. And history has to be comprehensive. The last case, and I will just 2 minutes. 6-year-old girl, 2 minutes long convulsion in the classroom, normal temperature, teacher complained. Parents are terrified, but there is something hidden. This was the first unprovoked seizure as per the history, but there were some hidden things in the history, like teacher was complaining that she was deteriorating in her school performance for the last 6 months. Parents also reported that she is getting involved in a daydreaming. So what was this daydreaming? What was those events? So how do you approach to this child? So very important, daydreaming has to be taken seriously in this particular age group of a child. 6-year-old female, 2-minute generalized seizure, but recent onset scholastic backwardness and daydreaming. So what is the maneuver you will do in your OPD? Hyperventilation. Look at the face of this kid. Very classical absence. Okay, and there is an eyelid myoclonia also. Okay, so this is one of the very important test of provocation, hyperventilation, and absence has got a signature on the EEG. Generalize 3 hertz per second waves. The first seizure. What is the important message from this? Very classical signature EEG of absence seizure. So the diagnosis is childhood absence seizure, the syndromic diagnosis. So what is the message? The first seizure may not be the first. Daydreaming has to be looked after seriously. If slightest suspicion, perform hyperventilation test. Some percentage of absence seizure may evolve to GTC. Absence has got a signature on the EEG. Very classical. So the syndromic diagnosis was childhood absence epilepsy. So this was very important paper from the Shiner, which tells that after the first unprovoked seizure, even you start early treatment or not, if there is no the long-term morbidity and mortality is not going to change. So my last slide, change you may wish to make in your practice. Confirm diagnosis of seizure based on clinical history. Exclude provoking factor. Do not perform EEG or neuroimaging for evaluation of simple febrile seizure. After a first unprovoked seizure, perform EEG and consider MRI. Do not use anti-seizure medication after first seizure to try to prevent epilepsy. Use only if benefits of possibly preventing a second seizure outweigh the risk for that patient. counsel families about seizure safety precaution, first aid after any seizure, abortive therapy. Seek experts' help or refer in case of a diagnostic dilemma or particular some semiologies, like even if with the first clustering of epileptic spasm, that is a medical emergency. My important message to practicing pediatrician: always uh, grab your first opportunity to refer that child to a pediatric neuro. Epileptic spasm is a medical emergency. Very important. So early referral when your child is not responding or diagnostic dilemma is there, and don't chase the EEG, treat the symptom. Thank you Bangalore, thank you Karnataka, thank you dear friend Nandish and everyone on the this virtual platform. Thank you all.
Thank you, Dr. Sanjeev Joshi, sir. It was indeed an academic feast that we enjoyed with you. Very excellent talk, sir. Very excellent. Let us look into the questions, sir. Now let us take the questions. Our Central IAPB member Lakshman Kumar, sir, has asked how to differentiate bilateral seizure from generalized seizure, clinical and EEG differences. Sir, please.
Sir, now according to the latest semiology, if at all I am not knowing the onset of the seizure and I am seeing the seizure as a bilateral seizure, I will still classify it as unknown onset generalized bilateral seizure. But if I have some observer who was looking after from the beginning of that seizure, and if he can tell me the semiology, exact semiology that the starting was generalized, that is categorized as generalized. So the observer's role is very important. And what was the next part of the question?
So how to differentiate clinical EEG wise?
See, EEG wise, even if focal EEG, if you have some focality on the EEG, then it is always suggest to you that there was a focal onset, but the child may have evolved to the bilateral seizure after the onset with the focal seizure. But if at all the seizure is showing the EEG is showing you some focality, some focal slowing or some focal spiking, then that is an absolute indication for doing an neuroimaging. But if at all, I have already told you, if your diagnosis is still in dilemma whether that event was seizure or not, 5% of the normal children or adolescent will have some focal slowing or spiking. So remember that. So I think that answers your EEG. So a focal signs on the EEG will definitely require a neuroimaging and definitely will require a treatment as well.
Thank you. Thank you for your clarification, sir. Another question we have here, sir. So your case scenario, pertaining to your case scenario, 7-year-old child fever provoked seizure, only one episode, no meningeal signs were there. AED is warranted in this condition, is it?
There was no fever, sir. The child was febrile. It was not a first seizure. Which case you are talking about? The third case, na?
Yes, sir. Yes, sir.
Yeah, the female one. So, see, here comes the paramount importance of the history taking. There were so many hidden things in the history, like recent onset scholastic backwardness, history of daydreaming. These has to be probed very thoroughly. So, it was not the first seizure. The child was getting clusters of the absence attack, which were labeled as daydreaming. Okay, so that's why and it is a hard known fact in the neurology that some semiology will evolve into another semiology, like few of the patients with the absence epilepsy will evolve into generalized tonic-clonic epilepsy. So this was the evolution from absence to generalized, but that event was not a first seizure. I think that created a doubt or what?
Yeah, clarified, sir.
But there was no fever, sir. There was no provoking factor.
Okay, sir.
So what else you want to ask in that?
Sir, can you just differentiate how to say that it's a daydreaming, whether it's a parent's perspective or clinician perspective. Can you give one example and kindly explain, sir?
So daydreamings are very infrequent, while absence comes into the cluster. And daydreaming is very distractible easily. Child in absence will not be getting he will not stop that particular event. These are very important. So more in numbers, clustering, and the daydreaming will be easily avoidable. And daydreaming will be in front of some witnessing, because daydreaming is one of the attention seeking episode. It is one of the behavioral issue. So अगर कोई spectator नहीं है, so that child will not do daydreaming. So that is very important.
Yeah, thank you, sir. Sir, you said in your presentation that some percents, 15% of healthy children will have abnormalities.
Sir, I have already
How best
told
can
you,
we explain that and how to do it?
whenever you are in doubt that that was a syncope, a very golden rule while differentiating syncope from an atonic episode. Syncope occurs when there is a stress. Syncope occurs in a setting. Syncope is preceded with some autonomic phenomena like sweating, pallor. So a pale child before falling is always a syncope rather than a seizure. If I have a story of that particular sequence, chronology, I will never do an EEG for that child. If at all that epileptologist or the neurologist report some slowing and spiking, उसको 2 साल का लग गया, ठोको. So
Okay,
that
sir.
has to be very, very well differentiated. So see, I have already told you, for every semiology of the seizure, you have an equivalent seizure mimic, and they are more common than seizure per se.
So clinical evaluation is more important
Yes, very important.
than the
very
laboratory. Sir, I have one more
And when never treat a EEG alone. Treat the symptom. Treat the child, not the EEG. Unless you have got a very specific epilepsy syndrome.
I have one more question, sir, from Dr. Abhishek. How to differentiate focal seizures with preserved consciousness or any other mimics clinically?
Sir, I have already showed you the video of a focal seizure with a preserved consciousness. That child was talking to the healthcare provider over there. He was still getting seizure, right-sided, tonic-clonic, upper limb and a facial. But the child was aware. The child was responsive. So now we use the term consciousness rather than awareness, because consciousness also include responsiveness.
Yes. Thank you for clarifying all the questions, sir. Now I open the house to discuss any clarification needed, any suggestion needed. I request the attendee members to clarify with Sanjeev Joshi, sir.
Sir, I am Lakshman Kumar, sir. Congratulations, Joshi, sir, for a wonderful, excellent presentation, and congratulations to the IAP Karnataka and IAP Bengaluru for initiating a wonderful the scientific program. Sir, my experience, one 10-year-old girl presented with unprovoked seizure, first episode, sir, but did not started the second episode. A child went into status epilepticus and needed a ventilation, and what he was almost referred to the Hyderabad 10 years ago. So what is the implication of that one, sir? Whether to
see,
because
if at all it is a
what percentage of children, if we don't start it without any risk factors, will land up in a status?
Sir, if what was how much evaluation was done at the first episode?
First episode was
EEG was done.
Yeah, EEG was done. So normal.
Yeah. It was normal.
But the second episode,
the most important thing is, sir, the age of the child.
But the girl went into status.
Sir, was there is any video recording of that particular?
No, that 10 years back, sir. 10 years back before.
See, you are talking about a juvenile age group, 10 year. 10-year female girl getting a first unprovoked seizure cannot be left alone without a thorough thorough evaluation. If your first EEG was normal, you should have gone for a sequential EEG or a video EEG maybe, because 10 year at the age of 10 years she is getting first seizure. It cannot be left alone. It has to be categorized into some specific epilepsy syndrome, sir. So I think the evaluation was improperly done and the counseling was not done. And of course, there are certain exceptions to the rules, sir. And your case was one of that rule. And I have already told you, if the first presentation is a status epilepticus, don't wait for anything. Load. Hit early and hit hard. With the loading doses of anti-seizure medication.
Thank you.
I think that if the child has landed with ventilation, but there was no any provoking factor, no trigger, nothing like that.
No, sir. The first episode was almost.
So what was the ultimate diagnosis, sir? What was the ultimate?
Yes, sir.
What was the ultimate diagnosis then?
No, diagnosis on epilepsy. They treated as epilepsy only.
So they did not categorize into any syndrome or something like that.
This is 10 years back, sir. 10 years back of the experience.
Okay.
So now from that experience.
Okay. I really feel, I wonder, there must have been some provoking factor. Yes, there must have been some provoking factor.
Yeah. No, sir. If it any EEG, some epileptic discharge is there in the first seizure. Are we right to start ASM?
Definitely, because the risk of seconds recurrence is almost 70%, and you cannot leave the child alone without anti-seizure medication. So there is a fine balance, sir. You have to maintain, you have to do the risk stratification. Sir, if at all there is only one seizure, like this 10-year-old child or a 15-year-old child, he is going on a two-wheeler to attend his regular coaching classes. There are no other risk factor, no family history, no any developmental issue. Developmentally normal, scholastically child is good. But a child is driving two-wheeler per day. I have to start some anti-seizure medication.
Is it mandatory to do the repeat EEG at the end of the ASM, sir? 2 years, whatever the 3 years course?
This is a very good question. Routinely, when you plan to taper down the doses of, it has to be a weaning, it has to be tapering down. You cannot stop on that particular day. So you have to slowly taper down the doses. It is not needed in all epilepsy. There are but only few epilepsies, like epileptic spasm, where after starting something like ACTH or vigabatrin, and if your hypsarrhythmia, which was there at the initial recording, it has gone, it indicates you that the child has not only responded clinically but electrically also. But routine EEG at the end of 2 years is not mandatory in all seizure semiology.
Thank you, sir. Thank you.
Yeah. Sir, one more question is that Dr. Bhagavan sir has asked when to stop AED in a post-meningoencephalitis without neurological deficit?
Immediately after discharge.
Good.
In an uncomplicated meningitis, immediately after discharge.
No, if it is meningoencephalitis, sir. If it is meningoencephalitis, then...
If your child is having normal neurology, if your child is having normal EEG, immediately after discharge. If some neuroabnormality, neuromorbidity is there, some focality on the EEG, of course you have to continue.
President Raghunath sir, you have one doubt?
Andisha, I just wanted to ask sir, how to differentiate this gratification syndrome with seizures?
Sir, this is the classical video diagnosis. This gratification again will be a particular age group. It is limited to toddler only.
Yes.
So if anything occurring beyond this age group, it's not a gratification disorder. Another thing more common in females than in males. The third thing is, if you address the child, there will be arrest. Will definitely will be there with the gratification disorder. But if at all it is a seizure activity, the child will not go into the arrest. If the child is in behavioral arrest itself while throwing some abnormal movement, that is not gratification disorder. Okay, and it will always be in front of some spectator.
Okay.
Yeah.
See, most of the children, most of the parents, they come to us with the parents' perception and the physician perception is that there is something or for the parents' sake of satisfaction, multiple UHGs are done. हमारे यहाँ मराठी में बोलते हैं कि पेट में कुछ तो भी हो गया सर, इसलिए उसको कुछ तो भी मतलब इसका स्कैनिंग करा लो पहले. So this is very common things are done.
Now, Dr. Bharti Madam has asked her, how long anti-epileptic to continue once it is started? Any prerequisites before stopping them?
So number one, it depends on what type of epilepsy you are treating. What was the categorization? Any epileptic syndrome or epilepsy syndrome was there, or without any specific diagnosis of epilepsy syndrome? What kind of seizure semiology was there? I have illustrated the third case, JME, juvenile myoclonic epilepsy. The standard teaching is lifelong. But the second case, the child with select nocturnal seizure. Okay. The select is self-limiting focal epilepsy with centrotemporal spike, which we used to call in our PG days as Rolandic Fisher epilepsy. And here the spectrum changes. Every child will select with an infrequent seizure, if seizure are 1 or twice in a year, nocturnal seizure, brief seizure, no daytime seizure, no frequent seizure, does not need even treatment. And if at all you are starting any treatment, the standard regimen is still 2 years. In a neurologically normal child, neurodevelopmentally challenged child is a different set of game. Neurometabolic epilepsy is a different set of game, and any structural epilepsy, secondary any structural etiology on the MRI is a different rule of game. For a general epilepsy child who has got everything normal structurally, no etiology could be found. A normally developing child with a so-called self-limiting epilepsy of the childhood, select is one of them, others are then SILAs, these are another 3 symptoms. The standard treatment regimen is 2 years. Because beyond 2 years, you are not going to achieve any further advantages of continuing with that anti-seizure medication. But always consider that in a normal child, the risk of recurrence is almost 20%. Irrespective of what epilepsy is there. But of course, in a neurodevelopmentally challenged child, some structural, they may be high.
Any more points, sir? Any more points anyone wants to ask? Dr. Yogesh Parikh, sir?
Yogesh Parikh, sir, is still there.
Yes,
Yeah,
sir.
I am listening, Baba.
I am really privileged and honored.
No. I am trying to log in through a computer, laptop, but only the 100 participants are allowed. So I am not able to. So it is excellent session by Dr. our Sanjeev Joshi ji, the neurologist. Excellent program, Nandish bhai, you have moderated, and excellent participation on the digital platform. So please keep it up, and we are with you. Just always, Nandish bhai, please invite so we can have a happy learning. Now I have a little more time to end the relaxation with the learning session also. Thank you very much.
That's why it is named, sir, Great Bangalore Connect. Connecting with great
Sir, Bangalore fraternities are always, they are having special blessings of the goddess Saraswati.
Yeah.
So it is the hub of
Prabhakar
academics.
Mishra, sir. We have esteemed guest Dr. Prabhakar Mishra, sir.
Sir, namaskar. Excellent,
Oh, so
excellent
nice.
workshop. Very
Yeah.
nice. And I joined little late, but it was an excellent presentation, sir. Thank you very much. Thank you very much. Thank you very much.
Dr. Ravi Shankar, sir. Just now he joined. Dr. Ravi Shankar, sir. Dr. Basuraj, sir, is there for closing remarks. Sir, Dr. Basuraj, sir.
He may attending other meetings.
Yeah, okay, no problem. Yeah. Thank you very much, sir, for your wonderful talk. And it was a great academic feast indeed. And
So really humble.
I'm very sure that this video will be spread across all the members and it will be very good educated to everyone.
Ravi Shankar sir is there, sir. Nandi sir.
Yeah.
Ravi Shankar sir joined.
Yeah, our IAP Karnataka President Ravi Shankar sir is there. Sir, your closing remarks, please, sir. Ravi Shankar sir. Unmute, sir. Unmute, sir.
I'm really happy about Raghunath and his team doing a wonderful job with respect to the academics and bringing Sanjeev Joshi as one of the renowned neurologists here as an expert and others here is a really great thing. Probably our IAP Bangalore people and across the India, because the Zoom meeting across India, probably a lot, many things have been learned by all the people. Thank you a lot, Raghunath. You are doing a wonderful job. We are proud of you. Thank you, Raghunath.
Thank you, sir.
Thank you, Ravi sir. Thank you, Ravi sir.
Thank you. Thank you.
Dr. Sunil Kumar, sir.
Yes, yes,
I
sir.
request you to please give vote of thanks and conclude the session.
Thank you, sir. Thank you, Dr. Nandi, sir, for a wonderful, you can say, convener job. Sir has done wonderful job. Thank you. First and foremost, on behalf of IAP Bangalore, led by able Dr. Raghunath, sir, and the team members, we thank the faculty for today, Dr. Sanjeev Joshi, sir, for sparing his time as well as his knowledge to all of us. We were truly honored to have you here, sir. Thank you. We thank Dr. Basuraj sir for inaugurating this session. We thank National President Dr. Neelam Mohan Madam, Dr. Singarvelu sir, Ruchira Gupta Madam, Dr. Alok Bandari sir, Dr. Yogesh Parikh sir, Dr. Atanu Badra sir, and the other stalwarts, notable among them Dr. Srinivas Kasi sir, Dr. Sumita Nayak Madam, Dr. Geeta Patil Madam, Dr. Ravi Shankar sir, Dr. Sahana Devdas, Dr. C.N. Reddy, Dr. Kushal sir, Dr. Priya Shivali Madam, Dr. Sarala Sabapati, Dr. Rajkumar Marol, Dr. Rajendra Salagare, Dr. Thiru, Dr. Ajay, Dr. Ashok, Renu Boralkar, Dr. Ghansham Chaudhary sir, Dr. Ramesh Panjania sir, Nigam Prakash sir, Lakshman Kumar sir, and Pravar Mishra sir. At the outset, I also thank Dr. Karthik Badrayan for doing the very innovative inaugural light lamping video for us. Thank you. And all the participants, more than 100 participants were there in the session, and more than 100, I think, waiting outside for a chance to get in. So thank you for this overwhelming response to the inauguration session of IAP Bangalore. Thank you. Thank you, sir. Thank you all.
Thank you, Nandi sir. Thank you, Bangalore Connect. Century not out. Okay.
Thank you, sir.
We are happy that 100 members stayed.
Thank
till
you,
the
Sanjeev
end of
sir.
the
Thank you,
talk.
Sanjeev sir. Thank you.
Thank you, sir. Nandi
Bye bye.
sir.
Good night. Good night.
Raghu sir,
Good
entire
night to
team,
all of you.
Bengaluru,
Shankara sir.
Karnataka. Good night.
Ravi Shankar sir. Good night,
Thank
sir.
you so much.
Good night to all.
Feeling honored.
Good night,
really.
sir. Good night.
Thank you.
Yeah, good night. Good night.
Thank you, sir. Thank you, Yogesh
Sunil
Parikh,
bhai,
sir.
Raghunath ji,
Thank
best
you,
of
sir.
program.
Good night, Nandi sir. Good night.
And
night, sir.
excellent coordination, Nandish bhai. You have kept the 100 people together.
Yeah, till the end of the talk, 100
Yeah.
members were there, sir. Very, very
Yeah,
honored
yeah.
we are. Honored.
Yeah.
We are very
No,
honored by the
it
presence
is
of.
your personal call and coordination to all.
Yes, sir.
I can understand that.
Thank you.
Thank you, bhai.
Thank you.
sir.
Good night.
Thank you,
all.
Sanjeev Joshi, sir.
Good night.
Good
Good
night.
night, Sanjeev bhai.
Nandi bhai, good night. Good night.
Good night. Good night.
Sir.
Good night, sir.
Good night, sir.
Sunil Kumar sir, close this
Sir,
session.
thank you, sir. Thank you, Nandi sir.
Raghunath sir, thank you.
Thank you, sir.